Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban. Welcome to episode 387 of the podcast. It is October 5th, 2020. My guest today is Seán Teeling. He joins us from Dublin, Ireland. He's the program director for the Professional Certificate and Graduate Diploma in Lean Healthcare at UCD Health Systems. It's University College Dublin. Seán is also an assistant professor in health systems through the Mater Lean Academy. He was previously lean manager at the University Hospital there. Now, Seán and I have collaborated a few times. I was invited to give a virtual lecture to a class last year through the Mater Lean Academy. I had the opportunity to visit the hospital and the Lean Academy last November, where I led a workshop for a group there on continuous improvement and the methods from my book, Measures of Success. So we did the red bead game, and it worked out exactly the same there as it does everywhere else. Seán has also invited me to review articles and to contribute an editorial to a special supplement about Lean and Six Sigma in the journal International Journal for Quality in Healthcare. So today in the episode, we talk about the Irish health system. We talk about Seán background and experience in both practicing Lean and teaching Lean. And here we also have the unique opportunity to hear from somebody who designed a COVID-19 clinic, and then he ended up being treated in that same clinic. And thankfully, Seán has since recovered and has been back to work for a while and is doing fine. So I hope you enjoy the conversation. If you want to find links to the journal and other things that we mentioned here, you can go to leanblog.org/387. Seán, how are you?
I'm fine, thank you, Mark, and yourself?
I'm doing all right. It's great to see you here through the Zoom meeting, and whether people are listening or watching this. I'm really excited that we're going to have this conversation, and we'll probably end up talking a little bit more detail about how I had the opportunity. Thank you, Seán, for the invitation. Or I think I sort of invited myself, but we had talked about me coming to Dublin last year. And so it was great to be able to spend a few days working together. And thank you for coming on the podcast.
No, it's great. Pleasure to be here. And thank you for the invitation. Thank you. So
can you let you start off and introduce yourself to the audience, your professional background, and we'll get into Lean and talking about that. But if you can introduce yourself for the audience, please.
Okay, so hi everybody. My name is Seán, and as Mark said, I'm working with Lean at the moment and Six Sigma. I am a nurse by background, and I trained in the 80s, showing my age, in London as a registered nurse. And then I came back to Ireland, but at that stage in Ireland, there was very few jobs going, to be honest with you. There was no shortage of nurses back then. So then I worked for a time in the States, came back, and then trained as a registered children's nurse in Ireland, and then stayed in Ireland after that. So basically, my background predominantly is obviously nursing and healthcare, but I spent my entire career, probably nearly 35 years, in operating theatres, operating departments, as you guys would call them in the States. So I suppose I think that people who work in those type of process-driven environments where everything is very smooth and, to my mind anyway, and everything is very ordered, it has to happen a certain way, would sort of I have that type of personality anyway that likes organisation. So I suppose Lean would appeal to me. So that's my background. And I then went into project management, worked on hospital bills, and gradually sort of drifted into Lean. It sort of was a serendipity that brought me into Lean, I suppose, way back then.
So do you remember what those moments of serendipity were, of being first introduced to Lean? It might have been kind of gradual, where you decided this is something you really wanted to get more involved in and start teaching.
Yeah, I think that, well, basically, when I was working as a project manager for a hospital bill. So I was working seconded to an organisation that was working for the Department of Health at the time, and they were building the new Mater Hospital in Dublin, which was 65,000 square metres of new build, new campus. And I had our director of nursing at the time, who had become our CEO, and our director of quality were very interested in looking at a way to improve process. And then my manager at the time, Laura, was very interested. She was involved in overseeing the design and build of the new hospital. And she was a fantastic manager. And between the three of them, they really realized that we were building this new hospital, and we were basically taking everything we were doing and just transferring it to a new build. And we could see very easily at that stage, because I was involved with, I had about 50 stakeholder groups of different departments, clinical, non-clinical. And really, we could see that if they continued to do the way the things they were currently doing them in the old campus, like it was an 1860s building and a 1980s building, so there was big discrepancies in quality of the environment, we could see that it wasn't going to work. And that we had to look at a way to change things. So at that stage, the director of nursing, or who became CEO, had said she had heard of lean. I had heard of lean actually previous to that when I was doing my MBA in the early noughties, but it was more in relation to supply chain. And it was just something I did on my course. I liked it, but I didn't really engage with it. So now we were re-engaging with it then at that stage. It was about 2008, I'd say, probably. So that's really what garnered my interest at that stage, and everybody's interest. There must be a way to improve the process, because it's not going to work the way it currently does in the new building. And that really was where I started to be very interested in this idea of improving things before we moved. Now, I have to say, I must qualify that with we made a mistake, if I'm honest. Mm-hmm. And I've said this to everybody since. By the time we became interested in lean, we had already developed our plans. It was a 284 million project. So you weren't really going to redesign the hospital at huge cost architecturally and engineering based on your process flow. So actually, I'll be hands up. This was my first experience of lean, and I hadn't really trained in lean at this stage myself. We were starting to lean after the fact. So any of my friends who were involved in the build for the new children's hospital in Ireland, which is the most expensive hospital in the world, believe it or not, it's so over budget. I'm saying to everybody now, before you build it, even often do your process flow before you get near being built, and so we did bring lean to the new building, but definitely not as well as we could have, given that we didn't start early enough. That's my experience.
I think that's a fairly common experience, or I've heard people from different health systems tell a similar story, that sure, the ideal time might be at the very beginning, where now you can start deciding what goes where within the hospital and look at the higher level flows and, kind of put together so that form follows process, if you will. But, I think it is also the situation of better late than never.
Oh God, yeah.
You do the best you can of realizing, okay, now, here are the constraints we have. Let's do what we can process wise to make things work at least better than they would have otherwise or without lean.
Yes, absolutely. Yeah, I'd agree with you. Oh yeah, no, we had to start somewhere, and I'm glad we did when we did. Yeah. Absolutely.
Yeah. So I'd say don't be too hard on yourself for that. How this often goes. So you saw from firsthand experience working in operating rooms. What would you say, from your time working there, were the biggest, or maybe even still are, the biggest opportunities for lean in operating theaters or operating rooms, whatever we're going to call it?
Yeah, so exactly. So I think one thing that really alerted me to flow in my career very early on was working in a number of hospitals. We would have our patients coming into our anesthetic rooms, and they'd flow very nicely into our theaters. And then we'd have the next patient in the anesthetic room when one patient was still on the table. But we would get calls in on the intercom from the PACU, or the recovery room, or the post-acute care unit, saying, we're full, we can't take any patients. So now you have a patient anesthetized in the anesthetic room, and now you have a patient anesthetized on the table, which obviously is not good for the patient, or clinical risk issues, being under anesthetic too long. And you now have a block, a PACU. But that's further downstream because the wards haven't staff free to come and collect those patients. So a very early example of using, I suppose, process improvement without ever calling it lean, when I worked in another hospital in Dublin. I was working in trauma and neurosurgery at the time with a team there. What we did was we reversed the process. So what used to happen was the nurses from the ward would come and collect the patients, and we timed how long it would take them to come down, but they'd have other patients and they'd have all these variables. So we did something which I suppose was really, we just basically reversed the flow. We said that the PACU nurses would bring the patients to the wards. And people were saying, well, you can't leave them. But we're saying, but actually, we're always overcrowded. It's quicker for us to bring them back and hand them over and come back down. So that journey up and down to the wards and units was taking about 20 minutes, where the wait for the nurses to come was sometimes up to 40 minutes. And in the meantime, all the other patients were well cared for. So we basically just flipped it. So just quick process now, pre-spaghetti map and quick series of timings. And we sort of flipped it. So I think we were redesigning the process basically without ever calling it lean, but we were thinking like lean, I suppose. I think a lot of people in healthcare do that and have solutions, but they just don't think that their process is improving. And one thing I always say to people I always remember you saying, Mark, never underestimate the power of a small improvement, or it's the little things we do. I always say to people when I'm teaching, if you feel you've never been involved in process improvement, did you put a red tray on your desk for out mail or overdue? I said, and that is in itself, you've made a process improvement. It seems small, but it has a huge impact. And then I would obviously cite yourself. So, and
I'm passing along what I've learned from others about the power of small improvements. But when you talk about something that is on your desk or in your home, or you're making tea in your kitchen, that's a domain where people are empowered to make a change. And in so many workplaces, unfortunately, people have ideas, but they're either taught to not speak up, or they're pressured into somehow thinking that their idea is not meaningful, or that it's not their job to improve. And I know one thing you and I agree on is that we do need to involve the people who do the work. And so I guess my follow-up question to you is, things that you've seen happen where leaders are helping create that environment, whether it's surgeons kind of at a smaller scale in operating rooms, encouraging everybody to speak up and have a say, or more broadly at a hospital level. What are your thoughts on creating that culture where people can and do speak up?
Yeah, so I personally, I think in my own experience, this experiential, when we started working with the Lean Academy in the hospital and working with the university, we did have a bit of that, what David Fillingham College knows, we're not Japanese, we don't make cars, it's motor industry. And it's seen as coming from industry and its application in healthcare. And friends of mine who I had worked with who were colleagues from DOR would say to me, "Oh no, we don't want any of that." They would literally say to me, "We don't want any of that stuff." And we literally were like nearly standing on street corners saying to people who work with us, because people really didn't want to engage. And then we found a number of teams. There's about 60 people who wanted to get engaged and involved in training, like if you want to call it prototype training, just before the university. And we worked with the campus development team. And there was one particular consultant who wanted to work on improving door-to-needle times for stroke patients to really save lives. So he worked with us. So I suppose the lesson I learned there and we had huge results. So that went from 80 minutes from door to needle time and 44 or 46 minutes from door to scan, down to 44 minutes from door to needle, and then to 16 minutes from door to scan, which basically meant we were saving lives and stopping patients being paralyzed. That was 200 stakeholders, 800 stakeholder engagements in 18 months. And a team of us working on that. But after that, other teams start going, "God, that's really amazing. We'll have a bit of that. How did you do that?" So what I always say to people is, personally, I said, don't be discouraged. Somebody out there wants to change. Just find the other person who wants to connect and then work with them. And then if you have a success, other people will start noticing and going, I'll have a bit of that. And actually, my colleagues, Aileen and Michelle and Vanessa and Maria, who I know you've met in Dublin in the Lean Academy, will say to you, when we started this about, what I remember, 9 or 10 years ago, we literally were trying to sell our wares, for want of a better word, come and work with us. Now it's like, to get it in that hospital, in the Mater Hospital, you have to actually nearly book a slot, and there's a long waiting list. So we just kept going and worked with whoever would work with us. And for me, but then that incrementally started to make the change. And I think the culture piece comes for me of, and I'm saying this as a nurse myself, traditionally, doctors are trained, nurses are trained or educated, and they do it in silos. And I suppose we always aimed from day one, even when we started, if I'm honest, and our director of nursing or our CEO at the time will tell you, there was a push to train doctors and train nurses in Lean or in Six Sigma. And I just kept saying, no, it has to be interdisciplinary. It has to be. And that was my battle at that stage at the beginning, to be able to sort of say, no, it has to be everybody. And that includes, we've had medical secretaries, painters, electricians. The entire hospital have to be involved in the improvement, because it's not it can't be elitist. And I don't mean that in a bad way. It can't be clinician, and I think that's where the culture change came, because people were going, oh, I can do that. So it's equitable, it's fair. And I would say it was an organic growth. So when I'm working with hospitals or organizations that say, oh, nobody's really interested, I always say, well, nobody was interested when I started. And we were literally dragging people to come and work with us. I said, so just work with a few people and start small. I do think there's a bit of a requirement sometimes from management, maybe, for a wham bam, it's going to happen now solution. That is not sustainable if you don't have that hearts and minds piece. And that's just my own experience. I think it's really winning people over and just working with those people.
Yeah. And so, I hear you touching on different aspects of improvement where we've already sung the praises of small improvements and engaging people in that. But then some of the things that you mentioned, let's say improving stroke care, that sounds like a bigger multidisciplinary initiative that does take time and engagement and coordination. Like it sounds like these are, if you will, value stream issues, that this is not coming into the operating room and telling anybody how to individually do their work. This is stepping back and also looking at bigger systems issues.
Yes, yeah, absolutely. I think so, and it's realizing, and I think that's where the really nice piece of scoping. I think one of the best lessons I learned very early on from my early engagement with Lean was from project charters was it's more important to say what you're not doing than what you're doing. Mm-hmm. So you're not putting these unrealistic expectations on staff to deliver something that's really not smart. And I've always said to people, I know what you're doing. It's what you're not doing you need to make visible, because otherwise, I always remember looking at this. There was healthcare assistant grade who assists nurses, and there was across 26 units in a hospital. And when we actually did observational studies, we could see, this is a true story, to clean a bedside locker beside a patient's bed in the hospital, the pantry staff or the catering staff would clean the tray part of it. The healthcare assistants would clean the top of the locker, and the cleaner would clean the body of the locker. So 3 people to clean a locker. Right. And this was just mind-boggling.
There's your silos.
Yeah, I just couldn't believe it, because I suppose coming from a theatre background, I was like, we wouldn't have seen that type of thing. So I was like, oh my God. So when the cleaning contract was coming up for renewal, there was a query, and I think it was a really good query. Could we take some of those duties off the nurses' aides and put it all into the cleaning contract, have one person doing it, because it's up for tender, get a really good cost, get it into the tender, And then we'd free up time. And when we looked at we did observational studies, we found that 40% of their time across 26 units was spent cleaning, that stuff that the cleaners could clean. So, but this is, I digress a bit, but you know me, Mark, I tend to waffle on, being very Irish. They say the Irish are full of loquaciousness and wit. So I don't know about the wit, but very loquacious. But in the scope part, the charter was really useful for me, because when we went to present this, I had done work with my colleague Aileen on 2 medical wards and 2 surgical wards, and we had done gambas and collected loads of data. And then somebody from finance said, but you said you were looking at all 26 units. And I went, no, I didn't. And I said, we had sent you the charter, pushed it back across the table, in scope, 2 medical, 2 surgical, out of scope, all of the units. So that was really supportive of me. The expectation was that we were going to, and even those 4 units took about 3 months to cover 4 units. So that was a really good lesson for me, where really thinking about saying what you're not doing and getting that recorded somewhere. Not that you're lazy, but that you're trying to level the load, you know, and be realistic, I suppose. So that was a really good lesson for me in Lean, I think.
Yeah, no, I don't think that's being lazy at all. It's keeping things realistic. We have to start somewhere. I've seen a lot of initiatives that around lean management system practices that went too broad too quickly, and if you will, it collapsed under its own ambition. Things went more broadly than there were coaches available to support people in things like daily huddles or problem solving. When I think when you go too broad too quickly, there's a risk that people struggle, and people are generally uncomfortable with that struggle. And then if they don't have a coach providing moral support and then there's the risk is that people give up and they say, oh, we tried lean and it didn't work here. Like, to me, that's the worst thing that could ever happen. And I think we have to guard against that.
Yeah, I agree with you. Yeah. I completely agree. And I think that's even from we've just had this conversation recently, as I was saying, we've more students. So we were sitting down looking at this with the team in the Mater, because it's a joint program with the hospital. And myself and my colleague Aileen, who's the manager there, were saying, it's great to have lots of students, but we don't want to have quantity and not be able to deliver quality outputs from the program. So we really looked at a mentoring program of we've other black belts within the hospital and within the system that we're saying, right, we really need to make sure everybody gets an equal share or gets the same attention. Not that Mark's team, he spends so much time with them and Seán Paul just gives them a cursory attention. So we really need to make sure everybody gets a good mentor, a good sensei, and supports them. And that's really funny, because we only had that conversation last week. But it's great having more students, but we don't want to not give them the same level of support. So that is an issue. I agree with you. Yeah.
And back to what you said earlier, when you're no longer having to push this on people, it sounds like there has been a lot of interest and pull generated managing that demand.
Yes.
Or the courses could be challenging, because I'm sure you don't want to say no to anybody. But again, it's like you said, it's not being lazy. It's not no, it's not yet, or not right now. Right.
Yeah, I agree with you. And I think part of the thing was we capped our numbers, and then we rose our numbers, and then we capped them finally. But I think the thing is, you could have lots of students this year who have a bad experience, and then word of mouth, it says, don't come back, don't go there. As you said, we've tried that and it didn't work. Or you can just have a number of students who are well supported, who deliver successful projects, who are empowered, I suppose, and become really good lean practitioners. And then you'll definitely have students next year. Whereas if you're just crowding them in, and it's not a quality experience. I mean, go back to the voice of the customer. If I have a bad experience with a service provider, I'm just not using them anymore. And at the end of the day, and I sometimes think, certainly, I'm not sure internationally it's probably different, but certainly in Ireland, sometimes when I say to people in class, at the end of the day, we are a service industry. Some people don't like to think of healthcare being a service industry, but actually, I say, but at the end of the day, we are a service industry and we have to deliver a service. But the universities are no different. We have to deliver a service to our students, who are our primary customers. So, I'm always cognizant of that. So I think that's really important. Yeah.
And so, since we are having an international conversation with what's usually an international audience, I was wondering if we could take a step back a little bit for people who are not familiar with the Irish healthcare system nationally. People may be familiar with the England National Health Service model. How would you compare and contrast differences in sort of the high level structure of the Irish system? And as a follow up, does that lead to any differences to how lean is positioned or put into practice?
Yeah, well, I think, I'm fortunate. I trained in the NHS as a nurse, and I know a lot of people in the UK would complain about the NHS, but actually I thought it was a fantastic system to train in and work in. Now, that was in the 80s. I know it's changed, but the NHS has been constant. Now, I know it's evolved into trusts and things like that. In Ireland, really, we've had a number of iterations. We had what we called health boards, and we had the Eastern Regional Health Authority. And then about 2005, they came up with what's called the Health Service Executive, which is, for want of a better word, the Irish NHS, but it's not like the NHS. Mm-hmm. And basically what we have is we do have a two-tier healthcare system, very similar. We have private, public, private. And I think if you earn under about €200 per week, you get what we call a medical card, which will pay for your medication, which will pay for basically everything. So we have quite a good system for that. And we pay a universal social charge, which can be from anywhere from, I think, 2% up to 7% in our salaries, which would pay for that. So we pay, in my opinion, we pay probably Scandinavian level tax, but not for Scandinavian level of service efficiency, if I'm honest. So we have all the bottleneck issues. We have patients and trolleys. We have, and I think what has happened in Ireland is that there was always a focus on acute care. So when I was working in Ireland in 2001, our minister at the time, Brendan Howlin, introduced this policy called Quality and Fairness, a health system for you, which was going to introduce community structures, like really good public health centres, like more public health nurses. And all that was in 2001. So now we are in 2020. We have now a new initiative called Sláinte Care, which is going to deliver that in 19 years later. Now, when I trained as a student in London in the 80s, we had public health nurses, we had district nurses, we had community midwives. In Ireland, you'd have a public health nurse doing all three functions. And we had really good public health, community public health systems. So the problem we have with the Irish healthcare system is no matter how efficient the hospitals are from door to door, there isn't the structures and the systems really aren't there in the community to support the discharge. So a lot of the blocks to flow within the organizations are getting people home. 70% of our patients go home, but the 30% who go to long-term care or rehabilitation or respite care or some other destination are obviously the people who spend a long time in hospital, and then we have all the delays. So I would say we've had a lot of change. Interestingly, COVID has made things flow very fast. I mean, unfortunately, everything could be done. There was money appearing from nowhere. Everybody's remarking on this. It's just me, all my colleagues who work in healthcare. And now that we're in post-COVID, and I say that with crossed fingers, things are reverting back to normal. So I suppose that's where there's a lot of good in the Irish healthcare. We have, we've children under 6 receive free care. There's a lot of good stuff. But one thing we don't have is we don't have a lot of general practitioners or GPs who work very, very hard. We don't have a lot of consultants, and we certainly don't have a lot of nurses, and we don't have a lot of beds in the system, which were taken out in the 80s and never put back in. So my analogy, which is probably terrible for the Irish healthcare system, but I've heard it somewhere years ago and I've used it since, is that the Irish healthcare system is like, I think we talked about this before, it's like a big cake. Mm-hmm. So I've got a huge big cake. I've been given this cake. It's a lovely cake. It's domed, it's glazed, it's full of candy peel and sugar and currants and raisins and sultanas, all those nice things. I didn't shop for it and I didn't bake it. And I actually hate currants, sultanas and raisins. So most of us are working in a health service that is like that cake. We can chop the top off the cake and cover it in frosting and call it a carrot cake. But guess what? It's still full of all those things we don't like. So I think a lot of us are in that situation. And I think that's probably the same internationally. Probably a lot of people are working in a system that they're redesigning because they never designed it in the first place.
Right.
Yes. And I think what you said there is really important because I think most Irish people who can access public care have private healthcare insurance anyway, as a stopgap to jump the queue, I suppose.
Yeah.
Really, that I think, but contextually, I think Ireland is different to the NHS in that regard. It's very Irish model.
Yeah, and are the hospitals and healthcare facilities government owned and run, or is there a mix of government run and private?
So we have what we call the HSE hospitals, who are health service executive hospitals. We have voluntary hospitals then, which would have been hospitals that were under would have been under orders of nuns, like the Mater I worked, like the Mercy Sisters, the Mercy Nuns, and then there would be private hospitals. And again, there's been a boom in private healthcare in Ireland. I mean, I work with about 5 private hospitals at the moment, as well as the public hospitals, with myself and my colleagues, and they are very big adapters of lean. Certainly, they are very big adapters of lean. That they've been. The public definitely, but in the last, I'd say 3 years, I've seen the private hospitals just seem to just run with it. Definitely, yeah. But it's a mix. I think it's probably the same as the UK in that regard.
Okay. Well, yeah. Thank you for sharing some of that context, because I'm going to paraphrase Dr. John Toussaint, who always says half jokingly, if you've seen one lean transformation, you've seen one lean transformation. And for my American audience, when we think of the different health systems around the world, whether it's to the north of us in Canada or England or the Netherlands or Ireland, if you've seen one country's health system, you've seen one country's health system. That they're not all the same.
Absolutely, yeah. Context.
But
in fact, even departments, the contexts are different. It's interesting. I think I always remember this when we were doing that work with the nurses' aides or the healthcare assistants, and there were 26 units, and all of the units had the same job description for this grade of staff. But when we actually went and asked the managers what they were doing, 26 different. Nobody was doing anything the same way in any unit. So it was very interesting.
And so that story and that scenario is fairly universal, across countries. So I think that's in my travels. It's interesting to see the high-level health system can be very different. The structure of who pays, who employs the medical staff, who owns the buildings. But now when you get into the details of how care is provided, where is the waste? Where are the problems with flow or quality? Much of that tends to be fairly universal, because to use your cake analogy, we eat cake here as well. And like you said, why has the cake always been that way? Yeah. Nobody remembers who came up with the recipe, right?
Very good. I like that. Yeah, it's very good. Very true.
So I am curious, before we talk about more about the lean education and get back into that, I am curious if I can get your thoughts on, some of the public discourse about healthcare in Ireland, because I think one thing is fairly universal. While the United States is notorious for having the most expensive healthcare in the world, as is generally measured, in many countries, people aren't happy with the current expenditures around healthcare. So I'm curious. The question is, how much do you see in the press or even in political discussion around cost pressures related to healthcare, and how much do you see discussion around access, patient safety, or quality of care? In a lot of countries, it seems like the cost discussion really dominates. But how is it in Ireland?
I think Irish people are very vocal. We're not afraid to say what we, as you can see, we're not afraid to say what we think. So there isn't a day that goes by, I suppose, in Ireland where health isn't in the press, whether it's in the media, on TV or news streams or Twitter or whatever, or in print press. Some people call the Minister for Health, the portfolio in Ireland, it is sometimes known as the poison chalice, more so than any other, because it is such a huge ministry, and it is actually known in Ireland as the poison chalice. So I think the issues tend to be emotive issues that you see in the press. I don't think it's so much the cost. It's things like we have the nurses, INMO runs a very good trolley guard that checks the number of patients that are waiting on trolleys in ERs. But it's usually stuff like my father spent 20 hours on a trolley. They're the sensationalist stories that the press will run with. But then we've had a lot of scandals in Ireland. We've had cervical smear test problems where women died who were given the wrong information. They were told they were clear and they weren't, and then ended up dying for it. We've had, I think, for me, in Ireland, things. I suppose it's a bit, it's not so much the poka-yoke, the prevention rather than the cure. So years ago, unfortunately, a lovely Irish woman who I didn't know, but I know her story, called Susie Long, died of bowel cancer because she didn't get her screening on time. And that generated the National Bowel Cancer Screening Programme in Ireland. But it's almost as if something terrible has to happen. Or a reactionary something is put in place. And I think that's what the press would be telling you about, all these stories of this happened and then something does happen and there's agitation for something to happen. And I think that the importance for me of lean disseminating around the country, or lean thinking, just thinking, or even the philosophy of a way of thinking, for me, is that people are thinking that, like poka-yoke, the prevention better than cure. This didn't need to happen. Where did the process fail? How does this happen? And I think that's what the press would run with, those more horrendous, I suppose, stories, because they sell. I don't mean that in a bad way, but that's what you'd hear. Now, so the only big cost issue that has been in the press recently is that the National Children's Hospital in Ireland, which is being built, has now become the most expensive children's hospital in the world, and it's not yet open. And that is obviously generating lots of headlines, not so much with COVID now. So it's things like that. That's where the money is being discussed. So issues like that, where how are we going to staff it? How are we going to equip it? This is just for the build, and it's already the most expensive hospital in the world. This is true. So I'm sure it'll be the best. But so they're the money stories about where money is wasted, would be in where they build something. But for example, the hospital that I worked as project manager on was building a children's hospital on site. With us, we were going to have a combined children and adults hospital on site. And then it was coming there, then it wasn't, and there was planning permission issues. And eventually they pulled it and moved it to another site. But there was, I won't quantify it, but there was millions of euro, and it is in the press in Ireland, of planning went down the drain. So they're the things that get the headlines, I suppose. So the cost would be in relation to wasted money, in relation to that could have been spent on something else. But the most of the headlines are the more emotive things about personal stories and horrible experiences, really,
Sure. And I think one thing that's a struggle in American press coverage of healthcare is when there is some catastrophic patient safety failure, people often don't connect the dots to these being common and systemic problems, right? So we play the blame game of who messed up, and people think these are isolated incidents, as opposed to being happening way too often, and not isolated. So that's a challenge. That sounds familiar.
Yeah, I think for me I always throw up just very quickly a pie chart, which the Deming, the 94/6 on the screen, and I always say to people now, where is the process failing? If 6% of it's down to human, and then 94% gives us lots of margin to find out what's going wrong, where the failure points are, and I really see that with people, and they go, oh, actually, that they nearly feel okay, that's good because it's not the blame culture. But the traditional approach, I suppose, and myself from working clinically, patient delay coming to the OR, oh, the unit didn't send them down in time, or the porter didn't do this, and we always blame somebody. And I personally, I have found as I've worked with lean over the years, that I do think it nearly neutralizes that blame culture, because if people are thinking, where's the process failing, they don't point the finger. And that for me is just amazing, that people are actually not blaming and personalizing failure of a system to individuals, which is terrible, really. So I've seen that shift in culture where people have moved away from that way of thinking to a far more system focused. The system is failing, not the person in it.
Yeah. That's great, and that's again, I think, something that's fairly universal human behavior and universal organizational behavior that we can learn from or draw inspiration from or talk about across borders. But I wanted to ask, I wanted to hear more about the Modern Lean Academy.
Okay.
And you've already touched on some elements of it that sound great. The interdisciplinary teaching, easier said some days than others. Interdisciplinary teaching to break down silos. But can you tell the audience more about the academy? Maybe even I don't know how much you want to get into the history of it, but how did it come to be? Who helped sponsor it? Who is involved, and what's the approach that you take?
So basically, we had the campus development had been working on. My boss Laura we'd all worked together on getting this initial lean program up and running, and we worked with a lean trainer who was external, and we'd about I think 60 people went through the program, and it was if I'm honest, it was good, but it was a bit ad hoc, as in people came when they could, and it wasn't they just came and did a bit of training, but they mightn't turn up every day, so they might miss, say, sessions on Kanban or 5S, but they pick up something. So it was a bit ad hoc. So at that stage, I had done my green belt, and our CEO was saying, we want to do this, but we need to cost save. So I actually went to her and said to her, I was working in quality at the time because I had finished with the build, and I had moved back to finished my secondment, and I was working in quality. And I said to the CEO, I said, train me to be a black belt. I said, we can do this. I said, and we can build our own capacity. I said, but you need to invest in me. And it was expensive. And she said to me, she said, okay, basically what's in it for me? And I went through, I said, well, we can build up our own capacity. I'll be able to be a full-time black belt, be able to train people, blah, blah, blah. Anyway, this worked really, really well. And she supported me on that. I went off to my black belt training. We started talking about getting more greens trained. And then because we were partnered with the University College Dublin, we started talking about working with the university and actually getting academic accreditation. So I suppose the reason I say that is because when I did my OR certification in anesthetics and scrub, the year I was going to do it, it was a certificate. But the year after, if I waited a year, I'd actually get a university diploma with credits. And I knew that I waited a year because I wanted to get a university qualification. So I said, look, really, if people are doing this work, all this work, they really should get something for it. Now they should actually get something they can use credit for education. So everybody agreed, and then Mark McNamara was the dean of nursing and the head of school at the time. He agreed with us. My colleague Mary in the university as well. So basically, we all came together and said we can do this. So we put together the programs, and we developed a joint appointment with the university, who would be a black belt who would work between the hospital and university. I was the lean manager at the time of the academy. And then from there, we started just doing training. We kept it in-house first, only trained our hospital. Then it moved to, there's 11 hospitals in our hospital group with 10,000 staff. So we started taking people from there. And then suddenly other hospitals start saying, oh, we'd like to do what you're doing. Will you take us for training? So we said yes. So then suddenly this demand built up and it became an issue. So we have two strands. We have the team in the Lean Academy work with me in the university. So I moved on, and I actually moved into that post when that other black man left. So I moved to university. So I work between the university and the hospital. So in the university, I would lecture and teach and work. And then in the hospital, I would work with practice groups of qualified lean people, and would work with my team there, or not my team, our team there, on rapid improvement, on value stream analysis, on projects locally. But likewise, the team in the hospital will then mentor students from the university. So we have a really nice, it works really nice. So they get to keep up their theory component and work practically with lean. And I get to keep up my theory component and actually work on the ground with lean as well. So it works really, really well. And that's where we are at the moment. And to be honest with you, this year, as I was saying to you earlier, Mark, we thought with COVID that we didn't even know if our programs would run, but there just seems to be this huge interest in people wanting to make improvement. Now they've seen things can happen. So it's a very nice, it's a very, I would say it's very symbiotic relationship between the Mater Hospital and the university. We just work really well together. I think because I used to work in that role in the hospital before I moved to university, we've just a lovely team in the hospital, and I work with some fantastic people in the university as well. So it works for everybody, I think, and I have to say, I genuinely have to say that I actually love going into work because I love the people I work with. They're just such a nice team. So I'm very lucky, and I think that's part of the success story, is the team, really.
Yeah. Well, I really did enjoy the opportunity to come and visit last year. I joked about inviting myself. It's a that's not completely true, but there had been previous invitations, which I appreciated, and the opportunity to give a remote lecture for the class. And then last fall, I was already in Europe as it was. I was in the Netherlands. I was in Switzerland. I thought, oh, well, it's a short hop to Dublin, and I'd never been to Ireland. So it was a great opportunity to help teach in person, but then to go walk the Gemba in the hospitals and to meet the people in the program. And thank you again for that opportunity, Seán Paul.
You were fantastic. It was great having you. Yeah, we had a great time. Yeah, really enjoyed it. Yeah, your workshop was fantastic. So I was very energized. We all enjoyed that. Yeah,
I look forward to a day when that sort of travel becomes possible again, so that we can, because the learning goes in all directions, and the inspiration goes in all directions. So that was it's nice reminiscing about that for a minute. But
it is, yeah.
But back to the brutal realities of 2020 and the impact on COVID. There's I know elements of your personal story this year from a professional standpoint and a personal standpoint. Maybe first off, if you don't mind, professionally, that you were back into clinical care. Could you talk a little bit more about that experience, and how is that different now that you have this lean lens, if you will, realizing that it was probably really difficult difficult environment with everything going on?
Yeah. Well, I suppose first of all, I think for me, so what happened was when COVID obviously struck, like graduations and things weren't happening at university level, and I work a split between the university and the hospital. I would be a joint appointment. I'd spend time in each. So what I did was I still had students that I had to close out because they were coming up to they were submitting assignments and stuff like that. So I upped my days in the hospital. But initially we were doing algorithms and process mapping, stuff like that, and running data. and then my colleague Maria, who was fantastic. You met Maria, Mark. She's a black belt, and she's just the nicest and most wonderful person, but actually just such a sharp brain and fantastic. She's a black belt with a pharmacy background, just the most wonderful woman. Maria and myself were then, we wanted to do something, not just sitting in the back room running data, because we were both used to being upfront. Not that that's not important. And I was like getting emotional and saying, I'm just going to put on scrubs. I just need to go and do something. Because everybody wanted to do something we were calling it nearly the national effort. We all wanted to do something meaningful, because everybody was scared, let's be honest. So what we did was, one of the consultants, Tara McGinty, had in the infectious diseases, had talked about another clinic which was just in trial period, where patients with respiratory illness were sent home on monitoring if they were well enough to work, and if it was well enough to work. So we worked with the hospital and with a company who ran those monitors, and we looked at a situation where we were trying to basically stop the hospital becoming overwhelmed. So what happened was, we designed a COVID clinic, and the idea from scratch, we literally put this together overnight. So what happened was that patients who would come in who were COVID and had symptoms were being admitted. So we very quickly realized that we couldn't take every patient in who had COVID. So the consultant said, well, look, some patients have symptoms, but they're well enough to be at home. So what we'll do is we will monitor them. So we need a team of people who can monitor them remotely. So we need nurses, we need people who can ring people, because in the Mater Hospital we did our own in-house testing, so who can ring people and give them the results, who are used to breaking bad news, who can give them the good news that they don't have it, who could advise them then on what to do, what will I do with my family, so we set out an algorithm, and we started off with that, and it was all very straightforward. And then suddenly we realized this wasn't going to work. We had to be agile, because on our team we had people who this department. So we had medical social work, we had 2 audiologists, Nina and Rula, on the team, fantastic, just the most fantastic team. And we came from people I had never worked with, or former students, but people I had never worked with, because there's 3,000 staff in that hospital. Right. It just became this really tight-knit team within days. And as we were working, people were saying, oh, what about homeless people? We've no pathway for that. So quickly, we have to design a pathway for homeless people. We need to talk to the community. What happens with homeless people? How are they looked? People who are living in a house, migrant workers who could have 20 living in a house. What do we do? Where do we isolate them? Then there's hotels they can go to. What's the pathway for that? What about, we just came up with all of these various pathways. Then we found out people who we'd sent home who got ill were coming in and going through the clean stream, for want of a better word. It's not clean stream, but we already knew they had COVID. They should go another way. So we started off with this pathway, which developed into about 20 different pathways. So literally, we were joking nearly that every day, it was like a hydra. Every time we sorted a problem, another problem. We literally were inventing pathways. Mm-hmm. And that meant huge stakeholder engagement, as in talking to the community, talking to district nurses, talking to reporting results, talking to the Department of Health. And literally, now I cannot take credit because Maria was there all the time. And Maria, Michelle, Vanessa, just a fantastic team. And then all of the guys, I can't name Jeremy and Seán and everybody, Rula, everybody, I could name them, I can't name them all, but there's a fantastic team in the clinic. So basically, we got it off to a fine art, especially with our occupational health team, Dominic Nathan thing. We had it off to a fine art where it was running like clockwork. Patient presents, we knew exactly where to send them, and we had all the resources, even to a point where somebody could ring me and we could actually have the ambulance collect them to bring them to where they needed to go, so they bypassed the ER. It was so fine-tuned. And then we had about 500 patients on monitoring at one stage. So once it was set up, then I started to I started to adopt my more clinical role of the nurse. So patients who had been diagnosed, who were ill and who were at home, a lot of them would deteriorate and would have to come back into the hospital. So you needed clinicians working on that. So myself and my colleagues, Seán, Jeremy, Nelly, a couple of the others, we predominantly did the clinical piece, and then the guys did the pathway piece and the organizing everything else. So, and they would ring people and tell them, I'm sorry to tell you that. And, ringing somebody to tell them, at the time everybody was so afraid of COVID, you might say, I'll just ring and give them the result. You could be on the phone for 2 hours counseling the person. So, it really was everything, counseling, clinical, everything like that. So it ran really well, really efficiently. We used to courier monitors out to people's houses. We'd send them home. Don't worry, the monitor would be there the next day. We had a whole protocol for how they would deliver them without being in contact with leaving the people. It was nice. So basically, I'd say we were very agile because we literally were adapting as it happened. Mm-hmm. So we weren't actually with patients physically. We kept the clinic separate so that we could all work together in a big cohort of people. Yeah. So.
Yeah, well, it's great hearing about that agility because especially in uncertain times, it would be unfair to somebody to expect that somebody comes up with a perfect plan.
Yes.
You discover new needs and new circumstances and being, whatever word you want to use, agile, nimble, flexible, adaptable.
Yeah.
That's all critically important.
I have to say, just on a personal note, I found the thing I found most difficult was I tended to do the longer shift, the late shifts, say from 1 until 9 in the evening. Mm-hmm. And I hadn't done evening shifts in years because I hadn't been clinical in years. Nice. So it wasn't so much doing the shifts was fine, but coming home in the evening, walking through our city centre, that was completely deserted. It was really, there was nobody there. It was literally like a ghost town. Yeah. And I found that very, very weird. I just found it was like an apocalyptic movie, just because you could only be out at that stage of lockdown. You could only be out if you'd meet a policeman and you'd have to show your hospital ID, I found that very, very derealizing. I think it was like something out of a really bad movie, so the work was great. Then you'd be all buzzed and then you'd go out and you go, oh God, this is terrible. Sounds weird, but that was what mentally I thought that was quite affecting,
Yeah. So again, just coming back to the question around, so being back in frontline care after learning lean, practicing lean, teaching lean, how would you compare to years previous when you were working the operating room? I know there were a lot of differences, but did you have opportunities to speak up and participate in some of that improvement work?
We did, yeah. Basically the clinic, we were given the clinic and we designed it. So Maria and myself designed it with my colleague Michelle, 3 black belts. And then we were really fortunate in that most of the people who were in the clinic with us, working with us, we had lots of green belts. Or we had people who had done the white belt, the introduction to lean. So nobody was unfamiliar. And I think this is where the hospital has over 1,000 people who have done at least the introduction to lean. So it's well known. The great thing about the hospital is as well, it's been there so long that most people know what it is. So you were pushing an open door saying we should do this, we should do that. And then again, it was very, I suppose, to use the person-centered from Edinburgh, from Brendan and Janet, it was very collaborative and inclusive. So we would sit down and have a huddle at 2:00 and say, okay, this didn't work this morning. Any ideas? Yeah. And anything went, anybody. So it wasn't just we were designing the processes, but everybody was feeding into it. So, it was very collaborative, very inclusive and very participatory. Everybody was participating. So it was very much, nobody was the boss. And I think a really nice thing Maria did was we had to do a roster. And traditionally when I was a nurse manager, I would do a roster and say, Mark, you're working Monday, Tuesday, Wednesday. Sean Paul, you're working Thursday, Friday, Saturday, and you're working these shifts. Maria made the conscious decision to leave the shift on the shared drive and you could just put in what you could work.
Oh, okay.
So nobody was told, but we all just decided. And then we would just we had a group app, and we just say on our phones, guys, we've 3 shifts, we've nobody to cover. And then you'd have a look. So actually, there was never a shift that wasn't covered.
Wow.
Now, coming from a clinical background, I have never seen that because people were always just told, these are your shifts, we need you to work these. But that clinic was never not covered. And there was never a roster. The roster's there, put in what you can work. And that's what we did, which I think was amazing.
Yeah. So from command and control scheduling to more collaborative scheduling.
Oh, yeah. Which I've never seen. I'll be honest with you, I've never seen, because if I was a manager again, I'd be going, no, I just need to cover those shifts. I would find it hard not to revert. Yeah. But in fairness, I give Maria all the credit. So I'm just putting it up there. I'm not anybody's boss, which was, but that's a measure of the person she is. So,
So you had this interesting mix of roles as somebody who helped create the clinic, somebody who was working in the clinic, and then kind of going back to the personal side again, you were also a patient.
Yes.
If you don't mind sharing a little bit about that experience of being a COVID-19 patient.
Yeah. So I suppose you and just to say, everybody was doing everything right, washing our hands, isolating in that clinic. We all worked in separate rooms because it was actually an outpatients clinic. So we had like about 15 rooms. So none of us were really together. We all worked together, but we'd have huddles, safe huddles, and everything was fine. But then one of our colleagues, unfortunately, caught COVID. She was an infectious disease nurse, and then we got the phone call that you need to self-isolate. And I was thinking, well, actually, I wasn't near her really. And then I think there was 5 of us who were on the shift that she had been on. I think of the 5 of us, 4 of us ended up getting COVID. So, and to be honest with you, my father-in-law my husband's father had just passed away from COVID that week. So it was really pretty bad time. And I think there was 10 of us at the funeral because you just couldn't have people at the funeral. Right. I sort of felt okay because, I sing, I have a degree in music as well. So I sing, and I sang at the funeral, which was really lovely and everything. And then I just thought I had a bit of a headache after that. I thought it was all the singing. So anyway, I just really didn't feel well at the weekend, and I was starting to go down through the list. I had all the symptoms. So for when I was diagnosed, then I was sort of, in a way, it sounds really weird because I worked in the hospital, I could look up my own results. But when I saw my results, I actually burst into tears because I was just so upset that I had caught it, because I couldn't understand how I got it, to be honest with you.
Well, and to be clear, I wasn't blaming you for getting it, or I wasn't blaming anybody you work with.
No, yeah. I think it's just, no, of course not. No, I think, no, but I'm just saying we were all so careful, but you just don't know where, you're traveling on public transport. We were all walking we were all living, I suppose. It's out there. No, it's not at all. And none of us know where we caught it, to be honest with you. So what happened then was, first couple of days I was, I was okay, but then by about the 3rd day, I just really was really ill. I had really high pyrexias, very high temperatures, dreadful cough. I'm asthmatic. I was just short of breath, not sleeping, these sweats. It was just, I had everything that was going. And then nosebleeds, which apparently, I don't know, not very many people, but I had really bad nosebleeds. So I was quite ill. My husband's a nurse, as you know, Mark, so he was able to nurse me at home. But then the clinic were happy to monitor me at home because my hubby's a nurse. But and I know this sounds really weird because you think you're a nurse yourself, but when you have somebody ringing you saying, oh, your monitor's here, do another reading. And this would, I'm thinking of one of the nurses in particular, Olive, who's a nurse I had worked with for years, was monitoring me and saying, now I know you think you know this, but I'm just going to contact the doctor and we're just going to check you out. So the level of comfort that gives you, because you're even, people say, oh, you can nurse yourself, but actually you sort of can't in a way. You just need somebody to that comfort. So I actually ended up becoming a patient of the clinic, which was fantastic in a way because I felt so minded and so cared for. And they kept me on monitoring for about, it's 2 weeks usually, but because I was ill, they kept me on monitoring for 3 weeks constantly. And then after that, they checked in with me. And then they did like not an exit interview. Then I went into the hospital and I was checked out, and it was the leanest thing I've ever been at in the hospital. I went in, walked in the door, again designed by my colleague Heather, who's a lean green belt, but she's one of the managers in the area. She's fantastic, and Heather and the infectious disease team. So I walked in the door to the clinic. They said to me, go straight to x-ray. Went straight to x-ray, walked in, had my x-ray, and was out in about literally 5 minutes. Back down, have your bloods. Everything happened. I was literally in and out in 30 minutes. Everything done, with social distancing and everything. It was such a lean operation. It was fantastic. Again, designed by I can't take any credit for that. So my experience, and I actually then emailed Heather and copied the CEO of the hospital and the deputy CEO, going, this was just a fantastic experience as a patient to go to that clinic. So so I was very fortunate to be looked after by a fantastic group of people that I had actually had the privilege to work with as well. And then I came back, but I was gone for about 7 weeks. So by the time I came back, fortunately, things were starting to decrease. So the clinic was disbanded, or not disbanded, but it only had about 10 patients. It had gone from 500 to 10. So it is ready. The formula, all of the pathways are there. The great thing is, I don't mean the great thing, but it sounds terrible. If it happens again, if there is another, I won't say outbreak, if there is another, I'll say outbreak rather than a second wave, because they're saying that COVID's like a fire, a forest fire. You can damp it down, but it's not going out. Right. So they say if there's another outbreak, it's ready to roll. That's all we've learned, and it probably will be agile and adapt again. So it was pretty weird though to be a patient of the clinic that you have designed. So I'm glad we did a good job.
Yeah. Well, I'm glad you're feeling better. You're back to work, and the work you've done has of course benefited a lot of patients, a lot of people, and like I said, hopefully there won't be a great need for that again moving forward. But I think I want to thank you and applaud you for the work you've done to equip others to improve and redesign care, or as you said earlier, to design it finally. Equipping people with that is going to serve everybody really well, no matter what happens in the future. So thank you for that, Seán Paul.
Thank you, Mark. That's very good of you. I'm only part of a team of fantastic people, I have to say. So yeah.
But thank you so much for sharing your experiences, both recent and looking back a little ways. I'm really glad that we were able to do the podcast together. So it's great being able to talk to you.
Yeah, and you. Always good to see you. Yeah, very good. Thank you.
Oh, and I was going to mention also, and I'll put a link to it in the show notes. Maybe I'll ask you to speak to it briefly. The journal issue.
Oh, yeah.
That you had invited me to give some input on and to contribute a collection of, I guess, case studies and examples would be the words to use, right?
Yeah. So yeah, that's right. So we worked with the International Journal for Quality in Healthcare last year, and we produced a supplement. And Mark very kindly functioned as both an editor and also gave a very nice forward piece for the journal. So I think we have 6 or 7 case studies from hospitals in Ireland. I think most of them are the Mater, but there's one in Galway as well, just about the application of Lean and Six Sigma projects with teen students we've worked with around the country, and ranging from I suppose environment of care and flow to hip fractures and to stroke patient nutrition. So really nice projects, again, all interdisciplinary. So so there's that's available online, free. It's open access. So yeah, actually, Mark, that'd be good. People could have a look at that and see some of the work we were doing. Yeah.
Well, great. Well, I hope people will go check that out. And again, I want to thank our guest Seán Paul Teeling for joining us. It's going to be evening for you there in Dublin. So I hope you have a good evening, a good night, and good rest of the week.
Thanks very much, Mark, and you, and take care. Good to see you.
Okay, thank you.
Thank you.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.